Hello and welcome to another podcast. Today we're going to continue with medications and we're going to look at every emergency department's favourite, ketamine. Now ketamine's been used since about the 1960s, but its therapeutic use has grown and grown and grown over the years. Relatively recently it's become extremely popular in the pre-hospital world and the TCCC world in its use in analgesia. So the indications for us and ones that we're mostly focusing on today is its indications for just that pain relief. So it's used in trauma patients who have moderate and severe pain. Now we'll discuss more about this moderate and severe pain aspect in a bit and why that's important. It also mentions that it's used for people that are at risk of developing hemorrhagic shock or respiratory distress. Now the caveat to that is the primacy, it's all about pain relief. Ketamine is not a treatment for hemorrhagic shock or respiratory distress. It's just a better analgesic choice as opposed to opioids. It can also be used as an adjunct to opioids that you've already given for trauma patients who need a little bit more on top of the opioids that you can give, willing to give. And there's also a consideration that if you get to the point that giving more opioids can be considered dangerous, then you can give the ketamine. Now, it's best to start at the smallest dose of ketamine, which is our 0.1 milligrams per kilogram, when administering it with opioids, especially fentanyl. Now, if you were to have a closer look at its therapeutic range, it's best to know that it's used in oral form a lot for antidepressant. And on top of antidepressant, it's also used to treat anxiety. It started to be used for alcohol withdrawal. It's used for agitation, PTSD. And unlike a lot of other antidepressants like SSRIs or SNRIs, ketamine is unique in the fact that you can actually get effects just after one dose and relatively quickly. So SSRIs take about 3 months for the serum levels to kick in before you start feeling the therapeutic benefits, whereas ketamine, you can feel the benefits after one dose, and it can last up to 2 weeks in some cases, depending on the dose and the condition, which makes it a wonderful choice when dealing with suicidal ideations. When we start moving into the IV liquid form, then we have a range of effects, and its range also dictates what adverse effects you're likely to see. So when we're dealing with the analgesic side of the house, it's best to stick around that 0.1 to 0.3 milligrams, and that's usually enough for quick analgesia. It started to be used in acute asthma, not as a mainstream treatment, but there is papers that supports its use, and that sits around the 0.4 to 0.5. When we start moving up towards the 0.8 milligrams per kilogram, that's when you generally start getting partial dissociation. And at 1 to 2 milligrams is when you get fully disassociated. Now what that means is, you may have heard it been referred to as a twilight sedation. It's when the person is present, but they're not really reacting. Okay, they're pretty much like an out-of-body experience, and you can do painful procedures relatively safely. So it's a wonderful choice if you're setting a fracture, doing an examination that's quite painful. Is this a fully disassociation as opposed to full sedation? Can be a lot safer and a reasonable choice. If you want to sedate someone, RSI, it's a great drug for that. It sits around that 4 to 6 milligrams per kilogram. Now, as far as lethality goes of this drug, it actually takes a lot of effort to reach those toxic levels. So papers will suggest that 10 to 25 times the standard dose of 0.5 milligrams per kilogram is where you start reaching that lethal dose. They did a study in mice, and they were using it to treat seizure activity. Yes, it also does that. And what they found is the 0.5 milligram per kilogram was enough to stop the seizure activity, but they had to get all the way up to 11.8 to be fair, before 50% of the mice died. The other 50% basically just stopped seizure activity. So it, like I said, takes a lot of effort to actually reach those lethal doses. The point of this therapeutic range is we can use it to our advantage when we're dealing with analgesia, and we start looking at some of those clues that we move into of nystagmus, sedation, all those things to know if we've gone too far or how much more pain relief a person could actually get and still be within that safe therapeutic range. Having a closer look at the pharmacokinetics, it's a diverse drug. When you look at the IV version, it's obviously quite different to the oral version. So it's focusing on that. It is rapidly absorbed because it's highly water soluble. So it gets into the bloodstream and it's just absorbed. It's incredibly lipophilic as well, and it has a very high bioavailability in the brain and the spinal cord. So it's a very effective drug. As far as protein bound goes, the range varies, and the studies are pretty much all over the place. It's as low as 12 all the way up to 54, but that's usually dependent on how much load the patient has been given. 54% if you're going for that sedation, and around the 12% if we're going for that analgesic range. What that means is it has a relatively small peak effect range, okay? Usually about 10 to 15 minutes when you're dealing with analgesia. That's all the effects generally last for, but it stays in the system a lot longer. Its metabolism is primarily in the liver, and the main metabolite of action is norketamine. So that's the one that when we talk about pharmacodynamics, that's the one that we'll be referring to the most. Now, it's mostly excreted in the urine, and you get about 3% excreted in feces. Now, when we talk about the pharmacodynamics and how ketamine works, we have to caveat with the notion that ketamine is incredibly complex neurophysiology. It has an immense range of actions on the nervous system in particular, and it reacts with a lot of receptor sites. But the most important pharmacological properties of ketamines are due to it being a non-competitive NMDA or N-methyl deaspirate receptor antagonist. Okay, and that's where the analgesic and the sub-anesthetic doses is believed to work the most. It's got to do with this NMDA receptor antagonism, blocking them, if you will. Now, when we look at the NMDA receptor, that's a very, very important receptor, one of the most active receptors you'll find in the brain. It's very important for learning, your memory, and it also enables something known as synaptic plasticity. And what that means is it encourages a large amount of neural activity in the brain. So it allows for multiple messages to be passed on in multiple different pathways, is supported by this NMDA receptor itself. Now, when you're talking about pain itself, it's receptors responsible for the amplification of pain signals, which is why ketamine's most effective at that moderate to severe pain level. If you give ketamine to someone in minor pain, you're more likely to get more of the adverse effects than you are to get any of the actual properties associated with pain relief. It's also the same receptor responsible for developing that opioid tolerance. So if you have a patient with opioid tolerance, then ketamine can be a great drug to break that particular tolerance and still give the analgesic effects. Now, looking closer at the NMDA receptor, it's unique to most other neuroreceptors in the brain in the extent that it's activated by glutamate, same as a couple of others, the AMPA, for example. But in this particular case, it actually has to be stimulated by glutamate and glycine as well. So it has to be co-stimulated before it will actually open up. And when the receptor is at rest, it actually has magnesium binding within its pore. There's a site within the pore called the PCP site, and that's where magnesium sits during polarization, during rest. Now, when the NMDA channel is stimulated by positive ions, it doesn't actually get stimulated directly by itself, but indirectly by other neurotransmitters, mostly your AMPA, but also the other neurotransmitters that are found in that postsynaptic cleft. So it will remain dormant until the positive charge comes along and polarizes and opens up this channel. And when that happens, the magnesium moves out of the way and allows for a massive influx of calcium and sodium to come in and potassium to flow out, same as your normal depolarization state. The difference is this, as we mentioned, this synaptic plasticity, this is the reason that MDMA helps with that so much, because this is post the initial channel opening from the activating receptors. The MDMA will open up in order to sustain and pass on a lot other secondary messages and vesicles being produced because of the calcium influx. So it's very, very important. When ketamine is put into the system, it is a non-competitive, which means it will take the space and won't allow magnesium to sit there. So ketamine will block the channel completely, regardless of any action potential coming along. Ketamine will still block that activity, and that is the main actions that ketamine will do. So even in the presence of polarization, calcium will not influx, causing all those different secondary responses, and we won't pass on the action potential too. So it really slows down brain activity, which is why we have those associated, dissociated, and sedative effects from it. Now, if that wasn't complex enough, ketamine also slows down the uptake of your catecholamines, your dopamine, and your serotonin, which is associated with a lot of the other adverse effects. So catecholamines are responsible for your tachycardia and your hypertension because it's slowing down that reuptake. So we get multiple hits of catecholamines within the neural cleft, basically causing tachycardia and alpha effects as well. On top of all of that, it binds to your nicotinic and your muscarinic and your acetylcholine receptors, which is why it's sort of used in that asthma cases that we spoke about before. And it also has associated effect on your opioid receptors, being mu, kappa, and delta receptors as well. To the extent that if you were to give naloxone to somebody on ketamine, you will actually get less than opioid or sedative effects as a result of giving naloxone. And the last thing that we spoke about, does many, many more, but we'll just mention this one, is it actually blocks voltage-sensitive sodium channels as well. Very, very similar, in fact, to your lignocaine. So it'll actually cause your local anesthetic effects on peripheral nerves because of its sodium channel blocking capacity. Now, it's not an alternative or a good choice instead of lignocaine, but it just does that as well. So that's ketamine. We won't even mention all the mental health effects that it has on the AMPA and all these other receptors, but that's the main uses associated with its use in analgesia and links to associated adverse effects. So moving down, we'll look at things to consider when giving our ketamine. Now, because we mentioned that ketamine can be administered post-opioids, we obviously have a choice of opioids that we'll give. It's fentanyl versus morphine. Fentanyl is really the opioid of choice when dealing with trauma. It's a lot more titratable, easier to give, but it has a serious interaction with ketamine. Now, that doesn't mean you can't give ketamine if somebody has had fentanyl. It just means that you need to know that if you put ketamine on top of fentanyl, you can actually increase those sedative effects, which is why it's important to start with those 0.1 milligrams per kilogram doses when dealing with it. If someone's on morphine, you still got to watch them because they're both seen as depressants and sedatives, but its link is nowhere near as great. Talking about links, there's probably around 250 different drugs that ketamine interacts with, but when we're using it the way we are in the analgesic emergency space, a lot of those interactions become somewhat null and void. Now, adverse effects, again, many adverse effects. Most of them are associated around the mental health line, generally when we're dealing with long-term use or higher-end use. The dangerous side effects is associated with laryngospasms, and that laryngospasm is mostly caused by hypersalivation because of that acetylcholine response that we spoke about just before. Now, whilst this is extremely rare when dealing with your analgesic doses, it can happen. So postural positioning and even the use of low-dose atropine, not too low obviously, but low-dose atropine can help when dealing with the hypersalivation, obviously on your MO orders. Now, if the patient suffers from emergent agitation, that basically means as they come out of the dissociated state, they get quite aggressive, quite agitated, and it's relatively common when dealing with the sedative effects. We're talking 14 to 25% of patients in some cases can get this emerging agitation. At our doses, it's quite rare. But if it does happen, it's controlled as your acute severe behavioural disorders and generally given midazolam. Now, nausea and vomiting are very, very common side effects of analgesic ketamine. Okay, so ondansetron is a wonderful drug to administer when giving ketamine, as it is with the other opioids. Now, full contraindications involve sensitivity to ketamine, obvious, and even though we don't generally give it to peds, if you do have peds protocols supporting you, then check what's written, because 3 months is a general rule, but it has been graded up to 6 months is an absolute contraindication, and even 12 months is a precaution to really question whether or not you should be given it. It is a great drug, much, much lower doses for the children, but it's contraindicated for the very young. Now, if someone's suffering from profound hypertension, we're talking 110 over 180 hypertension, then giving ketamine can have associated risks. Also, if someone's suffering from a CBA, then giving ketamine can increase the risk of them getting a lot worse. Now, hypertension generally isn't a consideration with ketamine because of its catecholamine responses that it has. But if someone is very hypertensive, we're talking, well, just basically low enough to give them a low sedation score. So we're talking that reduced conscious state, then surprisingly, giving ketamine is not a good idea. Now, giving any opioid or pain relief to someone with a high sedation score is never a good idea. So just so you know, it transfers over to ketamine. When we're picking our doses, when we're choosing to administer this pain relief, we need to realize what the intent of this administration is. Now, when we're dealing with controlling someone's pain, it's very important to get into the habit that you want to give someone pain relief as quickly but safely as possible. Okay, because the longer somebody is in high-end pain associated with trauma mostly, the more physiological and physical effects they'll have long term. So we want to get their pain under control as quickly as possible. And ketamine is great for doing that because it kicks in very, very, very quickly. Okay, you'll often find that as you're administering ketamine, because it's a slow push, patients can start feeling the effects before you've even finished pushing it in. Okay, now, whilst analgesics not as common when you move up into that partial dissociated state, then yeah, that's what you'll find. So we want to give the doses. If we're given fentanyl, then we want to start low. Okay, if you're given morphine, starting low is not a bad idea as well. If you haven't given all those and you're starting with ketamine fresh, then a lot of protocols will support you rounding up to 5 milligrams as opposed to rounding to the closest 5 milligrams. That means if somebody should get 12 milligrams, then the protocol supports you giving 15. And it's better to start at 15 because we have a lot of fail-safes when we're dealing with ketamine. So as you're administering ketamine, you'll give the first dose, and if the pain is under control, the person's relaxed, maybe singing, maybe a little bit no longer in pain, then that's your indication to stop. You keep monitoring, 10-15 minutes later, check their pain, give them a little bit more. Okay, and it's a great indication with ketamine because it's very obvious that they're not in pain. They're not having normal conversations with you. Okay, so that's the first range. If someone's not in pain, you stop giving ketamine. It's a good idea. Now, with the ruling with nystagmus, nystagmus isn't the sign you wait for when giving pain relief. If someone is non-verbal and has nystagmus, that's a really good indication that they're actually sedated. Okay, so if you see sedation, meaning if you see nystagmus form, then you stop administering the drug, even if you're halfway through the push, because that's enough. Now, if you want to check for early signs of nystagmus and the patient is able to still follow your commands, then get the patient to look to the extreme left and the extreme right to see if you have that drawback bouncing effect of nystagmus. It can be a good, easy sign. Now, the third reason to stop is obviously when you reach your max dose of your protocol. Now, if you've reached your max dose of the protocol but the patient's still in pain, make a phone call. See if you can give more. So the patient is still stable, still in pain. Your goal is to get them under control. Now, if your protocol says that 60 milligrams is your max dose before you have to call in order to get special permission, even though it comes in a 200 milligram vial, doesn't mean that 60 milligrams is a small dose for analgesia. In fact, if you were to push the 60 milligram dose on a 75 kilogram patient, you'll be sitting around that 0.8 milligram per kilogram load, which is that partial dissociation state. Okay, so granted, giving it in 10-minute intervals, it's not going to be that high, but some people can be quite sensitive and you can get pain relief after the first dose. So always use those indications to stop, and you can always revisit it and give more pain relief if you need to. Okay, we'll just finish up with a few clinical take-homes. So understanding ketamine is one thing. Understand the intent of ketamine and the range of medication that ketamine allows us to work with is also very, very important. Always consider how you're going to administer these doses. Now, a very popular way for ketamine to come is 200 milligrams in 2 mils. The recommended way to do it across the board is to mix it so it's 10 milligrams in 1 mil. Now, that is no problems at all when you're dealing with sedation. When you're dealing with analgesia and you get a patient, when you calculate the 0.1 or the 0.2, they need to be given 5 or 15 milligrams, then you're in a position where you'll have to administer 0.5 or 1.5 mils of the actual solution, which can be very difficult to do, especially if you have to push it over a minute. Okay, so consider maybe if you're dealing with those doses, get inventive, have a look at some pediatric protocols to see if there's a way that you can titrate it down. Probably not to the 20 milligrams in 20 mils, which is often done with peds, but maybe you can halve it. Just decant half of it, dilute it further. Just don't think that you're stuck with the 200 milligrams in 20 mil regime, especially if it's difficult to administer. Because you're going to have leftover ketamine, always label your syringe. 10 milligrams in 1 mil written on it. And make sure when you're sticking the label on it, you don't cover up the actual indicators that you're going to need to control your doses. Now, because sedation is a probability of ketamine, some patients can get so comfortable that they'll actually collapse their own airway, basically like snoring, but a good snore that makes them desat. A lot of the times that can be fixed just by repositioning the patient. Putting a naso in, anything like that can assist the patient in getting that airway control and that saturations back up. If that immediate thing doesn't work, then you can use a BVM, but really you only want a BVM if there's associated respiratory depression as well. So if you don't need to breathe for the patient, don't really worry about the BVM, just use your airway maneuvers to give them their airway back. Now, if you have someone with a head injury or an eye injury, you can use ketamine, but just realize that it's going to make it very difficult to do any examinations after, especially when you're dealing with a head injury. So all the effects, loss of consciousness, all that sort of stuff can be associated with the ketamine, not the head injury, or vice versa. So for those particular ones, we do need MO approval. Because we're giving small doses into a cannula, hopefully not a running line, okay, but we're giving small doses. It's a good idea to follow those small doses up with a flush. If you're doing the flush, realize that ketamine needs to be given slowly, so the flush shouldn't be pushed in quickly, because if you've got an amount of ketamine sitting in the bung or sitting in the immediate line and you push it through quickly, then you've basically just given a push of ketamine. Okay, so do a flush by all means, okay, highly recommended, but push it slowly. Now, if you have a set of protocols that says to mix a dose in a 100 ml bag infusion, just consider whether or not that's a good idea. Now, generally speaking, if you're dealing with infusions, what you're really interested in is long-term pain relief that you can titrate based on a drip factor. Okay, it's not really indicated for you to put your 20 milligrams in your 100 ml infusion and then run that through the patient, especially when you're dealing with a trauma patient, because it means you're giving 100 mils of normal saline to a patient to administer 20 mils of ketamine. You want to get to the 60 mils, you're doing that 3 times, which means your patients just received 300 mils of fluid when they really shouldn't get any when you're dealing with trauma. Okay, so always consider whether it's a good idea or not based on your patient. It may make it a little bit easier for you, but it's probably not the best idea for the patient. Okay, that's it for ketamine. There was a lot to go through in this particular one, making it a little bit longer than the standard. I hope you found it interesting. Hope you got something out of it. Ketamine is an amazing drug. I think you're going to find many emergency workers that don't agree with that notion. There is a lot more that we could cover on ketamine, but this one covers off what I believe, anyway, you need to know when dealing with that pre-hospital space and using ketamine primarily as an analgesic. But until next time, take care.